together with my co-host Sean Strayer, we welcome you to discuss with us the wonderful world of psychedelics. Now, this has been a topic that has been interesting to me for several years now, and it is one that is surrounded in controversy. And it's an important discussion to have that we have today.
Absolutely, Ryan. You know, this is a topic that's gaining a lot. It's just being talked more and more about in both popular media and scientific literature. And I think with most controversial topics, there's just a lot of misinformation on both sides. So our goal today is to provide you with a nice review of the literature and the science so you can make an informed decision on your own.
That's a great point. I think most of this misunderstanding is coming from the emotional attachments to the issue at hand rather than the evidence-based facts. These psychedelic drugs have been in use for well over 9,000 years, and we have pictures of cavemen on the walls that are taking these psychedelic substances and having these psychedelic experiences. And they've been freely used up until very recently in 1970, where the drugs were banned under the United States Controlled Substances Act, and this act was deemed all the classic psychedelic drugs as well as MDMA under the Schedule 1.
Yeah, I know, it's incredible to think about all the cultures that have used psychedelics as part of their religious rites and in their cultures, and just how quickly that all changed as a result of that act. Now, a lot of the listeners, they're probably not familiar with how scheduling works as far as drugs in the United States. So can you just kind of go through that for us? Like, what's an example of a Schedule 1 drug, and how does that change from a Schedule 2 drug?
So the Drug Enforcement Agency in the United States, the DEA, has created a 5-class scheduling system, with 1 being no current medical use and high potential for abuse. And these are things like methamphetamine, bath salts, and heroin. And its sister, fentanyl, which is a Schedule 2 drug, has fantastic analgesic and anesthetic properties, and that's why it's under the Schedule 2.
So fentanyl is a Schedule 2 drug.
Correct.
Yeah, so, you know, I think that's where a lot of the people's public opinion has been skewed about psychedelics, because when I'm looking at a drug like magic mushrooms, and I see that it's in the same classification as something like heroin or PCP, I'm automatically going to impute that there's the same level of risk, right?
You're absolutely right. And but I think they're getting a little bored of the introduction. Why don't we get into the science of pharmacology behind some of these psychedelics?
I'd love to. Yeah, let's hop right into it. So DMT, or dimethyltryptamine, this is a psychoactive derivative of the indolamine metabolite tryptamine. And it's actually interesting because if you were to look at a biochemical drawing of the amino acid tryptophan, the only difference between tryptophan and DMT is the removal of a carboxylic acid group and the addition of 2 methyl groups on the amine moiety. And so DMT has really interesting pharmacokinetics, and we're going to kind of go into it now. I feel like it's an important thing to talk about when it comes to DMT. So we've identified 2 degradation pathways as far as DMT. One of them is the cytochrome P450 group of enzymes, but the more prevalent one is the monoamine oxidase group of enzymes. And so there's this theory that DMT is actually produced in our brain endogenously, but the reason we aren't tripping all the time is because we have these monoamine oxidase enzymes that help break it down to a non-psychoactive molecule. So when users, so it's not orally available, right? So when users want to get high off of DMT, they either have to smoke it or take it with a monoamine oxidase inhibitor, such as the case of ayahuasca that they use in South America a lot. And so, like other psychedelics, DMT binds to the 5-hydroxyltryptamine receptor, which is actually where serotonin naturally binds to as well. Now, when serotonin, or these drugs, they bind to that receptor, we get a G-coupled protein signaling cascade that the net result is a release of intracellular calcium. And as anybody who's taken physiology knows, this release of intracellular calcium, it actually depolarizes the cell by changing the resting membrane potential. So in a lot of the studies that we're going to be talking about, you'll notice that DMT is not really used in a lot of these studies because it's such a potent effect. So, you know, they're more likely to use something like psilocybin or LSD we get into. But it's really interesting because when people take DMT, they see these crazy geometric shapes. They get a disassociation, probably from a disruption in the default mode network. And the crazy thing is they see these spiritual beings that they describe as mechanical elves. It's very interesting. So Ryan, why don't you outline a drug that most of our users or most of our listeners have definitely heard about, which is LSD?
So commonly known as acid, I hope everyone has heard of LSD so far, unless you're living under a rock. So LSD is lysergic acid diethylamide, and it's a psychoactive substance that was first synthesized by a Swiss chemist his name was Albert Hofmann. And that was back in 1938. And it wasn't found to have those psychoactive properties until 5 years later when he went back and he was messing with his experiments and he got some on his fingertips and he went home and had a psychedelic experience.
That's crazy.
Absolutely crazy. So LSD quickly became a popular recreational drug in the 1960s, and it got banned less than 10 years later under the Controlled Substances Act of 1970. LSD has psychoactive effects, which is in doses as low as only 100 micrograms. We're talking micrograms, not milligrams,
yeah.
right? And it can cause synesthesias, which is the intermingling of senses. You have auditory and visual hallucinations, as well as like your typical sympathomimetic effects, like with an increase in heart rate. And these last around 12 hours. Your typical dose is around 50 to 400 mics, and it's ingested orally or absorbed through the oral mucosal membrane. LSD targets the same serotonin 5-HT2A receptors found in the central nervous system, and there's two pathways for this receptor. First, and more understood, is that G-protein coupled pathway, just like we were describing it earlier, right? Then you have the less known beta-arrestin pathway, and that serves to terminate this G-protein signaling, but it has its own signaling as well, right? So this transduction activated by the ergolines are likely responsible for LSD's effects, and it has a crystalline structure along with an extracellular loop 2 protein that serves to encapsulate the LSD bound in that receptor. And it's tightly bound to this 5-HT2A receptor for up to 15 hours. And some of our therapeutic applications of LSD has been limited due to the controlled state of the substance. However, a study done in 2016 by Peter Gasser and some others gave 12 patients with life-threatening conditions such as terminal cancer. And it was double-blind, placebo-controlled. They had drug-free psychotherapy sessions that were supplemented by 2 LSD psychotherapy sessions given 2 to 3 weeks apart. The participants were randomized to either receive 200 mics or 20 mics of LSD. The study used the state trait anxiety inventory as an outcome measure, and they found significant reductions at the 2 months and sustained at a year after the study had concluded. And to put a cherry on top of this whole thing, right, no adverse events were recorded, not a single one. And I'm so excited to see the future of the further research into LSD. So there's another drug with serotonergic activity, but it's not commonly classified under the classic psychedelics, and that's MDMA. So why don't you go into how this is going to fit into our framework today?
Yeah, so MDMA was actually synthesized back in 1912 by a German pharmaceutical company, and it was originally as it would propose to work to help as major hemorrhaging, but it really didn't pan out that way. And it really wasn't until the 1970s when a pharmacologist by the name of Alexander Shulgin was introduced to MDMA actually by one of his pharmacology students, and he started experimenting with it, and him and his wife, they noticed all these empathogenic effects. And that's a very important topic because a lot of people don't even put MDMA in the same realm as psychedelics. They put it in the empathogen category because you're not really getting these hallucinogenic effects. But after he was experimenting with it, he was just blown away, and he felt like his colleagues could use it in psychotherapy to really boost its efficacy. And that actually did happen from the 70s and 80s until in 1985 it was reclassed as a Schedule I drug. However, MDMA is still used today in a lot of the rave scenes and the club scenes. A lot of people call it Molly. But the problem with these settings in particular is we run into the issue of hyperthermia, dehydration, and then a very concerning one, which is the hyponatremia that can actually come from trying to treat the dehydration with water. And you've probably seen it a bunch at EDC. I mean, it's pretty wild stuff. So
right, I was talking to you that week actually, and I was saying I have all these patients that are having seizures, and we didn't know why. We're just so perplexed as why all these patients are coming to us and they're seizing in the crowd, and we have to go to them, right? And we had to do a little bit of research to find out why that was.
Yeah, But even despite that, David Nutt, who is a brilliant neuropharmacologist from the UK, his group, they came up with a list of 20 recreational drugs, and they ranked them from most harmful to least harmful. And this was harm to the user, harm to society, and they actually ranked MDMA as 18 on that list. So, that's just something to think about. And so it is a serotonergic, it has serotonergic affinity for serotonin receptors, but it also has effects at beta adrenergic receptors and alpha adrenergic receptors, and it kind of explains some of the sympathomimetic properties of this drug. So it is a little bit risky when we talk about, when people buy drugs off the street. MDMA is one of those ones that you don't know what it's cut with. A lot of people are putting things in like caffeine, ketamine even, and it's just, that is a big risk that we've identified. But, they are studying it again in clinical controlled settings. There was a Nature of Medicine paper that was published just in 2021, and they took a placebo group, and then they took a group that they gave MDMA to. And these were people with long-term PTSD and depressive symptoms. And what they found was just the MDMA group with concurrent psychotherapy, it was a significant attenuation in their symptoms, way above and beyond that of the placebo. So it's going to be really interesting to see how they integrate this into future studies. And this is another one that we're really going to keep out on our radar.
Right, that David Nutt study is definitely one of my favorites.
Yeah, absolutely. Very interesting. So Ryan, when a lot of people think about psychedelic drugs, the first drug that actually comes in mind next to LSD are the psilocybin-containing mushrooms. So can you go into the science behind that?
So a lot of people wouldn't classify psilocybin, they wouldn't recognize it, they don't even know how to pronounce it or say it. What does it even start with, right? Does it start with an S? But it's actually going to start with a P here, right? So psilocybin is going to be the psychedelic psychoactive compound that is produced in many species of mushrooms. And that's how they got their name, right? Magic mushrooms. These fungi, these fantastic fungi, have you seen on Netflix? It's great. So they synthesize these psychoactive compounds through I'm not going to get into the biosynthesis crazy, but these fungi synthesize these psychoactive compounds through a series of biosynthetic reactions, starting with the L-tryptophan, and they finally get to the active compound psilocybin. And so after you ingest psilocybin, it's going to be absorbed into the bloodstream, and at the jejunum, in the small intestine, it's going to travel to the liver via the hepatic portal system, and there it's going to alkaline phosphatase in the liver is going to remove this phosphate group off of psilocybin. It's going to turn into psilocin, which is a structural analog of serotonin, right? So these are all serotonergic agonists, right? So however, while in the liver, we're going to have this thing called the first pass effect. And so the first time psilocybin enters the liver, 80 to 90% of it is going to get metabolized to its inactive form, all these other metabolites that I'm not going to get into. And that remaining 10 to 20% is going to get into the blood, and it's able to cross the blood-brain barrier, the BBB. Psilocybin itself has a high affinity, a very high affinity for the 5-HT2A receptors.
Same receptors.
Exactly. It's in the central nervous system, right? And so it has a lower affinity for the 5-HT1A and D subunits, and it's activated via the G protein couple receptors. Oh, you guys should catch a trend here, right? And these receptors are responsible for a variety of functions in the brain, like body temperature, appetite, mood regulation, and your motivation to go and do things. And so we have differences in dosages, right? So typically in clinical trials, you have pure psilocybin, lab grade pure psilocybin, and that's not going to be available recreationally. And so these clinical trials are done, the participants are consuming anywhere from 10 to 50 milligrams. Milligrams, exactly, of pure psilocybin, but for recreational use, that's not available. So they're going to grab organic mushrooms, right, and they're going to grow their own mushrooms, and it's at a dose of 1 to 5 grams, and more is not always better, right? This is not one of those cases. And at a dose of 1 gram, your users are going to have a sense of euphoria and increasing motivation, but at these higher 2 to 5 gram doses, you're going to have that classic psychedelic experience that you hear about all the time.
Yeah.
And so some of these effects, right? So enough of the biosynthesis. You have these users that are describing these feelings of open-mindedness, super open-minded. Like they're saying like this is the most spiritual moment in my entire life. This is it. And you have the synesthesias again, and you have a mild time dilation effect. You have profound pupillary dilation. So that a lot at EDC. You just hockey pucks on these pupils, and you have an increase in heart rate, and that begins about 20 to 90 minutes after ingestion because it's oral, and it can last up to 12 hours, based on strain as well.
Yeah.
So some of the studies, this is some study back. It's been very, very small studies because of the scheduling on these drugs, right? So the two most recent and noteworthy to me were the Johns Hopkins University study and the New York University study. The Johns Hopkins University study, which included 51 patients, and it used a crossover design where each patient served as their own control. That was great. That was fantastic to me. And they received both an experimental high dose, the pure psilocybin at 22 milligrams, and a low dose at 1 milligram that served as an active placebo control. And in the New York study, it had 29 patients, only 29 here, and it randomized to receive psilocybin at 0.3 milligrams per kilogram, and the active placebo niacin in the crossover design involving one drug each session. Both trials had pre and post-treatment psychotherapy sessions and included patients with end-of-life disorders such as cancer, terminal cancer, and a range of psychiatric disorders in the mood and anxiety realms. I think this was a great study. Both studies demonstrated robust and immediate critical lasting effects well after the 6 months had passed. And they used a standardized measures of anxiety and depression, right? So we have standardized tests. And they used a state trait anxiety inventory, and both studies demonstrated excellent safety profiles of the experimental intervention group of the medically ill population. Symptoms of these studies showed they were generally limited to transient increases in blood pressure. That's from the sympathomimetic effects we were talking about earlier, but not a single adverse medical or psychological outcome was reported in either study.
And it's pretty incredible to think about.
Absolutely.
Yeah.
Not a single one. So there's the therapeutic potential of these psychedelics we've talked about today. I don't think it can be understated, right? These drugs induce cognitive, antidepressant, anxiolytic, and anti-addictive effects in the brain. And this is done by enhancing the neuroplasticity at the molecular, neuronal, synaptic, and even the dendritic level. That's the most important right there. So they increase brain-derived neurotrophic factor. This is a whole mouthful for you guys, but it's the BDNF, and it outlasts the acute effects of the psychedelic. So even though that trip only lasted 4 hours, you have lasting effects up 6 months and beyond from these BDNF levels increasing. And so this increases the dendritic spine thickness and density in the prefrontal cortex, it's the PFC. And it's thought that depression is related to dendritic spine atrophy in the PFC. So it's enough about mushies. So Sean, can you talk a little bit about how modern medicine is treating depression pharmacologically?
Yeah, so like you said, a lot of the potential benefits that we're talking about from psychedelics, it's in the context of mental health, particular PTSD and depression. And so you have some of these studies, but I just want to contrast it for you with how we're currently treating depression pharmacologically. So the most commonly employed drug in our toolbox for treating depression, treating symptoms of PTSD, are going to be things like our SSRIs, okay? That's a very common one. So the SSRIs, or selective serotonin reuptake inhibitors, they're a class of drugs that they help increase the transit time and also activity of serotonin in the synaptic cleft. And this comes from the monoamine hypothesis of depression, which says, hey, we have a global decrease in our depressed patients of neurotransmitters like dopamine and serotonin. And so this helps by having more serotonin in the synaptic cleft. So unlike, there have been drugs in the past like SNRIs or TCAs, these are some of our older antidepressants, but the problem is they had more activity outside of the serotonergic realm. They would affect things like dopamine, they would affect adrenergic receptors, and there was a lot of side effects that came from that. Now, SSRIs, the reason they're used so frequently is because they have less effects because they're more selective to serotonin, right?
Right, it's like the first generation versus the second generation.
Exactly, and that's why SSRIs are used so much, but there's still some really bad potential problems.
Definitely.
I mean, from something like QT prolongation to even suicidal ideation in younger patients, okay? And that's the major stuff. I mean, we also have things like dizziness, weight gain, loss in sexual dysfunction, okay? And anxiety is an actual symptom, a side effect that is caused by a lot of SSRIs. So, and I mean, if you think about, so another thing that we worry about with serotonin, the SSRIs, is a thing called serotonin syndrome. So if you have too much serotonin globally, and this could be done by either abuse of SSRIs, or a lot of these patients that take SSRIs they have comorbid conditions that would make them take another drug that also increases serotonin. And you get this really nasty syndrome that it's basically a medical emergency. And I guess the whole point that I'm trying to make here is just because a medication is commonly prescribed, that doesn't mean it's always best for the patient and without harm to the patient. And that's true across all medicine, but particularly in psychiatry, right? And so what I really hope the field leans towards, I hope they start studying these drugs more. And we should study any type of alternative therapy that comes with less side effects, right? Like you said, in the psilocybin studies, there was no adverse outcomes, and that is truly remarkable. I mean, can't overstate that enough.
Right, and all these SSRIs, SNRIs, all these classic antidepressants, Gen 1 and Gen 2, all have this black box warning on them. Like the first 2 weeks, you're gonna have an increase in suicidal thoughts, even though these patients are already feeling suicidal. I think that's really dangerous.
No, it's very high risk, and it's accepted, because we've been using it for years. It has decent safety profile, but medicine is always changing, and I think we should start. I hope the field adopts some of these other medications.
Definitely, I definitely agree. There's a lot of things in medicine like that.
So Ryan, another psychedelic topic that has basically gone viral online is the idea of microdosing. So can you explain that for us?
I have heard a lot of recent people talk about microdosing to me, and I didn't know enough about it, so I went and dived into the research myself to get educated just about the subject, right? Like I'm not going to tell you my opinion about it, because my opinion doesn't matter. The science of this matters, right? So it's really uncharted territory. This is what I found. There's no real studies about this, and it's had been growing in popularity. So the world of microdosing, right? So there's the practice of consuming subperceptual, very, very low doses of either LSD or psilocybin, and these are the mushrooms, right? Not the pure psilocybin. You gotta keep that in mind. And so the scientific literature contains very little research on this practice, and there's been limited reporting on adverse events associated, because these layman people that are growing their own mushrooms and taking it medicinally,
it's all at home.
They're not going to report to some form or any study.
Of course.
And so the dosing is 50 to 200 milligrams, right, of ground dry mushrooms.
So
right?
about 0.5 to 2.20 grams.
Correct.
Yeah.
Right.
2 to 0.5.
No. 0.05 to point.
Gotcha.
Thank you.
0.05.
There we go. So
our dimensional analysis is off.
a little bit. So these are the dried mushrooms, and this is a weighted dose, and it's still subperceptual. And then users typically take around the 100 dose, and it's around 3 to 4 times a week, so they don't have the tachyphylaxis build up with psychedelics. And so they have a self-reported increase in mood, motivation, and they have self-reported significant reductions in anxiety and depression. There's many forums where they're just talking about how they just hopped off of their SSRIs or their SNRIs and they've been great for years, right? And so they were talking about how they were blunted. They were blunted forever on their SSRIs, and they weren't living life to the fullest, and they were able to hop off of those medications safely, I hope, under a medical practice, and use these psychedelics, these microdosing psychedelics.
Yeah, I really hope we get some study on this, because it really, the way I think about it, it makes me wonder, so if we have an 80% first pass effect by the liver of something like psilocybin, it makes you wonder, if you think about it, they're only getting micrograms of the actual active drug.
Right.
And so it makes you wonder, is this placebo? Is this a true thing? I guess we're just going to have to wait and see.
And I can't wait to wait and see.
Yeah. So in a lot of these studies, they talk about the idea of set and setting and environment when they talk about delivery of psychedelic drugs. So can you just go ahead and explain to us what they mean by set and setting, and then how environmental factors play a role into the experience?
So that's a really famous saying. You talk to any user, they're going to always just define how important the set and setting is, right? So the set is the mindset at the end of the day, and this is anything from religious beliefs or traumatic past experiences that can still be lingering in your consciousness, or even like subconsciousness at the end of the day, and that's at the time of ingestion. That's pretty important. And so instead of the internal world of your mind, we're talking about the external world when I'm talking about setting, and that's all about what you're surrounded with during this psychedelic experience.
Yeah, and we talk about set and settings, it sounds like there could be a positive or a negative connotation with that, right? A negative context. So does it seem like, from what you've read, does it seem like a negative set and setting might set somebody up for some of these bad trips or other negative outcomes?
Oh, 100%, without a doubt, right? So it's directly influencing what's going on during your psychedelic trip. If you're having a bad set or a bad setting, or you're just not in a good place mentally, you're just not going to have a good time while taking psychedelics.
Yeah. And so it kind of makes you think back to all these settings. I mean, I hope they figure it out. I'm sure the medical community, they found ways to ensure that these patients, that they have these right set settings, right?
So every study I've read, 100%, right? The door's locked, there's a sitter in the room, there's this trained psychoanalyst with them, a trained psychotherapist that provides psychotherapy sessions at the end of the day. They're not just gonna give you a psychedelic drug, walk you into the forest. Here's some trees, here's some mushrooms, and good luck, have a good time. It's not going to happen.
Yeah, absolutely. And I mean, it kind of brings up the whole topic of, and I mean, you can correct me if I'm wrong, but it seems like a lot of the benefit with the psychedelic drugs is the inclusion of this integrative psychotherapy. I mean, it might not just be the macro dose alone, but it's the concurrent psychotherapy that helps people get through these traumatic experiences and break these walls down.
So that's a great question to pose, and I think there needs to be more research into that, right? So they need to do more clinical trials to see if it's just the psychedelics influencing the positive outcomes, right, from the BDNF factors and everything like that, or is it the psychotherapy combined with the psychedelics that's giving us the positive results? And so that's a great, interesting question. So, I mean, we just need further trials on that. I couldn't tell you at the top of my head whether they would have reduced reduction scores or anxiety scores solely on one or the other alone.
Right, and it makes you think kind of mechanistically. You mentioned these things like BDNF, and we talked about how these mechanistic actions independent of psychotherapy, they might be playing the role in this. But I mean, if you look back at somebody like Freud, right, you talk to someone like Freud, the original psychotherapy, right, they would use things like hypnosis and meditation and relaxation to kind of put them in a mindset that they can actually work through these deeper rooted issues, right?
Yeah, those Freudian psychotherapists, they were great. I loved them. The Freudian psychotherapy stuck around for a long time.
So to wrap things up, we really want to drive home the point that we feel like we need more research in this domain, okay? And whether that's from purely a harm reduction standpoint, or when we're talking about true clinical applications, we need to have, for something like mental illness, we need to have these studies done, and we need to see if these negative side effects that might not be coming up right now, if there are negative side effects, we need to tease these things out, okay? I mean, we would never go ahead and do studies this small for any other type of pharmaceutical drug, right? So why would it be any different for something that we're considering using in the world of psychiatry?
Yeah, right. It's a result of big pharma at the end of the day. I think big pharma, they're not going to make money off these drugs. It's a lot cheaper and a lot more effective than buying these SNRIs for the rest of your life, rather than you can grow your own medicine at home. And I'm not endorsing anything at the end of the day, but that's going to be a big influence.
Yeah, I mean, you also can't patent something like psilocybin. It's just impossible.
And the world needs to change. The world's idea of what psychedelics are, what they do to the human mind, and how people treat them, that needs to change before we see a definite change in medicine.
Definitely. I mean, it's going to be very interesting to see where all this research goes, but As always, we really hope you learned something from this podcast, and we truly can't wait to see you next time. So, take care, keep healthy, and keep on learning.
Yes.